75% of white Americans have zero friends of color. Zero friends of color. And 2/3 of black Americans have zero white friends. So what does that mean? Our ideas of one another are oftentimes created by not us, not our personal interactions, but by the media, by our parental figures, by people of influence. And that also creates a physiological response in the body. Fear, contraction, an inability to make eye contact, social distancing. And these have very much physical manifestations that we can now track. Dilation of pupils, sweat. So the cool thing is we can understand what the bias itself is and where it's enacting, and then be able to introduce tools to mitigate it.
Okay, I'm stopping you because going back toward the solution.
I just whispered.
You're a solutionary. You can't help yourself.
I know.
Okay, Maria, let's come to you now. Are you a solutionary?
I guess so.
Do you even know what that is? All right,
Yeah.
we're going to find out. We're going to find out.
I think I like it. Yeah.
All right,
I think I
Maria
like it.
Vertkin, tell us what the problem is in your from where you sit, in your vision. How do you see racial inequality affecting access to justice?
So in the healthcare system, racial inequality can be seen in so many different ways. And one of the facets that I'm going to talk about is language. And, it's kind of a basic thing. It's not as hidden as implicit bias. And yet it's something that people don't hear about often, aren't as aware of. So essentially, if you're a patient that doesn't speak English, and you come to get medical care from a doctor or any other provider who most likely only speaks English, your visit to that doctor is kind of like a dog's visit to the vet, where you can't communicate. And actually, I was just speaking with Anu, and we were talking about this, and I actually slipped up. I was going to say, the other day I took my dad to the doctor, and I said I took my dad to the vet. Yeah.
True story.
And it's kind of funny, but it's also, like my heart sinks when I think about that. And it really was kind of like that. I have a dad and I have a dog, and the experience of taking them to get care is very similar because they can't communicate. And they're treated kind of similar, kind of you poke them there, and if they squeal, that's where it hurts. Whereas the rest of us can communicate. So what it looks like if you're one of the 37% of New York City residents who were born somewhere else, speak another language at home, when you go to the doctor, from the very beginning, you lose very basic rights in healthcare. Without language, there's no informed consent. This is something we take for granted. It's a basic right. And if you don't speak the language, that's not possible. You can't give a medical history, which is the most important part of a diagnosis, and without it, really, you're relying on unnecessary tests, and even that's not going to get you as far as actually getting a first-hand report of what happened. If you bring in somebody, like a family member, or you say, that the secretary speaks Vietnamese, whatever, we'll get somebody to help, you immediately give up the patient's right to confidentiality. So all of us have these basic rights in healthcare that we take for granted, that somebody that doesn't speak the language is denied. And, oftentimes a patient that doesn't speak English might have a family member or even a child interpreting, and there's so many ethical issues with that. Imagine a 9-year-old giving his mom a diagnosis of cancer. Happens all the time. And then, with that flawed information, if you have anybody at all interpreting who's not a trained medical interpreter, the mistakes can be deadly. The errors, inefficiencies, readmissions, deaths, this is deadly. People die from it. And so a lot can go wrong. And the good news is that there's this thing called medical interpreters. It's a profession where a bilingual person is trained in medical terminology, in ethics, in the healthcare system, and can facilitate an encounter between a provider and a patient, and does so confidentially, and they know what to do when there's a tricky situation that might turn deadly if it's your kid interpreting or the janitor or whoever. And another good news is that access to a professional medical interpreter is actually a legally protected civil right under Title VI of the Civil Rights Act of 1964. The bad news is that right often gets violated. And that happens for a variety of reasons. A lot of providers actually don't know that patients are entitled to this right. I think they might think of it as, patient preference or like an extra thing they might do, but they're not aware that it's a right and that it's illegal not to provide this, that it's illegal to ask a family member to interpret, that it's illegal to say, come back later when you find somebody or when we find somebody who can help you. You have to serve that person in whatever language they speak. And also I think sometimes the providers know but are able to get away with violating these rights because the patients who suffer from it are not, by definition, they don't have a voice. They don't have the language to speak up for themselves, and the patients might not know that they have this right. And a third problem, which is kind of where the solution comes in, I won't reveal too much, is in the interpreter workforce. So the immigrant population is growing fast. And in the US, we have some amazing medical institutions that also attract a lot of medical tourists, as they're called. So wealthy people from abroad who, if they have the money, come here to get their treatment. And these people need medical interpreters. And the population is growing, the population is shifting, and we don't have enough medical interpreters. And a lot of the people who have the skill, the language skill, who are bilingual, who could be trained to be medical interpreters, are themselves immigrants and face all the same, discrimination, bias, systemic barriers that keep them from advancing professionally, from being able to break into this profession. Is that too much of a spoiler alert? We train medical interpreters.
No, that was, I think that was a nice tease. Do you mind my asking a little bit more about, you talked about your dad, and
Please.
Is that what inspired this, what motivated you to get into this work?
Yes, so I'm myself an immigrant, actually twice. So my family moved from Russia, where I was born, to Israel when I was 6, then to the US when I was 11, and kind of through my whole life, I've been sort of guiding the grown-ups in my life through this maze of crazy things, adult things that they should know, and I shouldn't, but they didn't have the language skills. And, fast forward later on, I'm a social worker and I was working with, poor people. And poor people from all kinds of walks of life. But one thing that they shared was that way too many of them were people of color, way too many of them were women and single mothers, way too many of them were immigrants. And so I started to think, what can these people do who are living in, very difficult conditions, and there's just so much going against them. But a lot of them have language skills. A lot of them are bilingual. And this is kind of how the idea for my organization started, seeing that poor communities are rich in bilingual talent. And that's one way that people can use an existing skill set to get out of poverty permanently by becoming medical interpreters, earning more money, and helping others in their communities who need that service.
And the focus, as I said in the introduction, is on low-income women. So we'll come back to that in a bit. Let's come to you, Vineet. How do you see racial inequality affecting access to justice from your vantage point?
Yeah, I've always been fairly sensitive to the issue of racial inequality personally, primarily because I grew up in 4 different countries across the world and spent part of my time in the Middle East, where I sort of personally experienced racial bullying when I was 11, 12 years old, and did not speak the language, was not from that place, did not look like anyone else who was around me, and very significant anti-Muslim bias. So if you're not Muslim, there's a bias against that. It's sort of the opposite of what we have in westernized countries. And for me, that was very significant because I became forever sensitive to the issue of being different or being a minority in a place where the majority had a lot of power. Fast forward, about 10 years from that experience, I was in New York, actually, and I went to high school here in the Bronx, and was struggling with a lot of health conditions of my own, health challenges that had just built up over a lifetime. just poor lifestyle choices personally, and actually struggled with being morbidly obese and pre-diabetic at the age of 17. And I still remember having this conversation with my doctor. It was at Mount Sinai here in New York, who said, if you don't change what you're doing right now, you will be fully diabetic by the age of 20. And for me to hear that, and then my parents were both physicians, to sort of drive that home that same evening, caused me to make some very important decisions that ultimately led me to losing about 100 pounds over the course of my first 2 years in undergrad. And that experience was incredibly powerful for me for a couple of reasons. One, it was because it helped me address a lot of physical challenges. But secondly, and I think perhaps more importantly, it helped me become a lot more comfortable with change and a lot more comfortable with feeling in control of my own sort of destiny. And it feels kind of cliche or exaggerating to say that, but it's actually true. I became much more comfortable with my ability to shape my own future. And I spent about 6 months after that experience spending time with my dad, who was then working in Galveston, Texas, moved from New York to go work at a hospital there. And there was a significant natural disaster, a hurricane that happened in Galveston at the time. This was in 2008, 2009. That led to a lot of people losing their jobs and consequently losing their health insurance. And so my dad was like telling me about this experience that he was having. He was having trouble getting the hospital back on schedule, and this clinic that was affiliated with a hospital that was serving the uninsured in Galveston, which I didn't know this at the time, but actually had the highest percentage of the uninsured in the state of Texas, and probably by definition the country. And it was just telling me about it, and I became very interested in doing something. I was in high school when Katrina happened, and I was motivated by what I had seen on television. So I left school for about 6 months to go work in this medical clinic with my dad, and became instantly attracted to the work that was being done. I thought that it was incredibly powerful and moving. But one particular thing that I noticed throughout my experiences working with about 300 patients, getting this clinic back up and running, and doing everything from patient histories to physical exams to point-of-care testing for a population of primarily Latino and African American patients that were uninsured, was the fact that many of them came back over and over again to the clinic, but instead of getting better, they kept getting worse. And it was challenging to kind of see that, and a little bit disheartening to see that happen over time, because many of these individual patients had families that came with them. They had challenges and issues that had been compounded after years and years of disease progression, particularly for these chronic health conditions like diabetes or hypertension or chronic kidney disease and others that had essentially been getting worse over time. And one could trace the evolution of these conditions and the manifestations of them back to the amount of time and attention and care that someone had put in at the very beginning to make sure that person was adequately informed about what they had and had the right resources and tools to be able to manage that effectively. And the lack of that resulted in some of these manifestations that I was unfortunately being exposed to on a daily basis. And I think for me personally, that was incredibly sort of this dichotomy between the experiences that I had when I was undergoing my own transformation versus the experiences that a lot of these patients that I was working with that had issues that were far more significant than my own, yet had access to a tiny fraction of the resources that I had access to when I was undergoing my own transformation, with parents who were incredibly motivated to help me, great doctors, coaches, nutritionists, personal trainers, was pretty I think disillusioning. And I had been pretty sensitive to this whole notion of being in the minority and being someone that doesn't get what they should get and doesn't have an equal ability or access to get the right things that enable them to be successful, given my earlier experiences in childhood. And I became really interested in making healthcare more equitable and more accessible to everyone, given my own personal experiences. And I went back to school and sort of learned a lot more about this problem of how can we help patients that are from under-resourced communities and living in what are called MUAs, or medically underserved areas across the United States, get better care and be able to manage some of these preventable and manageable chronic conditions better, in a way that can help address probably one of the biggest challenges of our time, which is the rise of chronic disease in the United States and now globally. And what I found through that experience and exploration was that I personally discovered, sort of a dual set of challenges. You had, on the one hand, patients who were continuing to not have the adequate information, resources, tools to manage their conditions, prevent them from happening in the first place. So you had patients who had some challenges of their own, and on the other hand, you had providers and these healthcare institutions that were working in these medically underserved areas across the country, free clinics, community health centers, what are called FQHCs, or federally qualified health centers, and even large health systems that were providing charity care or indigent care, that were struggling with the rise of new patients that they were getting through the Affordable Care Act or other places, and yet had limited or even fewer resources to take care of this population. So you had a worsening demand issue. You had a lot of demand for a limited, finite set of resources, where it becomes increasingly more difficult to be able to provide, individualized or personalized care, particularly in these resource-constrained environments. And then on the other hand, you had a set of patients that, as a result of, years and years of neglect and lack of information and other challenges, were getting progressively worse, and their health was suffering as a result of that. In addition, and not to even mention things like access to healthy food options, or access to transportation to get to appointments, and other social challenges that were a contributing factor towards that. And so that was what I discovered as sort of a problem.
So given your level of empathy and sensitivity that drives your vision, how do you deal with the politics that surrounds the healthcare debate? Do you ignore it? Do you just keep your head down and continue to move forward in your work? Or do you engage on that debate or in that debate?
Yeah, we don't ignore it completely. I think we try not to think about it too much. I think that there are definitely aspects of the current political debate, particularly related to the Affordable Care Act, that has implications for our work and for the patients that we serve. But I think the problems that we're trying to solve go beyond any political debate. I think they're definitely affected by it, but it's a much more fundamental problem that we're trying to solve. People need care no matter what. And some of these issues and challenges that we have been trying to address, I think, are much more fundamental than politics.
Yeah, that's why I asked. And I imagine there'll be more questions about the ACA tonight. All right, which gets us to the solutions. Let the solutions begin. You all received this postcard. Did anyone not receive this postcard? I took your postcard.
No worries.
You can have it back.
Okay.
Did anyone not receive? You have some more? Anyone not receive the postcard? Did you not receive the? You got it? Oh, he did not get it. I was about to give you mine. All right. Everybody hold up your postcard, even you who are taking a photo. That's you. Yeah, thank you. Now you can take your photo again. All right. So this, you see there are three. Cheryl's nodding. There are three, we call it 3 by 10, we call it 3 by 10 commitments. 10 days, 10 weeks, and 10 months. Commitments we're going to ask of you. And rather than try and explain it in my awkward way, Jan is going to explain. And we're getting good at this. Jana's going to explain it. This is Jana Oberdorf. Were you introduced earlier?
I was.
Well, I'm going to take this opportunity anyway to thank you, because Jana's been our liaison for almost a year in helping to arrange this week of events and bringing these brilliant people to us. And Jana has made a commitment every night this week, which is amazing. Thanks because I made her. No, we've been talking every night about what this is all about, and to help us understand what it means to make a commitment. She made a commitment, so we get what it was all about. So she'll explain what this is, how they came to do this, and maybe give an example.
Yeah. So everyone has a card, as Jami mentioned, and the goal of this is really for you to think about how you can be part of the solution. We've just heard about some of the problems facing this issue, and they are many, but there are many ways that each of us can also step up to the plate and be a part of the solution. You'll hear more from these guys, some of their really exciting examples of how they're creating really big, dramatic change in the world. But all of us have a part to play. And so what we ask you to do is to think about what can you commit to in 10 days, in 10 weeks, and in 10 months. And really thinking of setting some short-term, medium-term, and long-term goals for yourself, writing them down, and then holding yourself accountable to actually achieving them. And we sort of have heard from the audience and often hear, for some people, short-term goals are really difficult. And for some people, thinking about 10 months from now is really difficult. And so sort of acknowledge that and think about why, and really push yourself to make those commitments and hold yourself accountable over time. Because we all can use what we know and what we are talented about to be part of the solution. I will give my commitment now. I will. I will.
Please do.
I feel like I have a good one tonight.
All right. We had a great one last night.
So in 10 days, I will march in Washington, D.C. for reproductive health for all women across this country.
That's a good one. That's going to be hard to top. Let's all march together. Yesterday we committed to do a flash mob on Rikers Island. So we're going to be doing awesome. That. So what we had happen the last couple of nights is members of the audience shared their commitments. You don't have to share all three, 10 days, 10 weeks, 10 months. But as you ask a question, you might want to share a commitment, or you can just share a commitment, or you can just ask a question as we go forward. But while you think about what you might write down on your card, let me ask you three, have you ever seen anything like this strategy before in your work? Or have you ever thought in these terms before? Short-term, mid-range, and long-term solutions? Because it seems like a good way to keep from getting overwhelmed, even in one's personal commitments and goals. What do you think, Anu?
Of course. I mean, that's basically how we run the organization. We have this larger aspiration of eradicating bias, 2040, right? It's 23 years away now. So that's kind of a long-term commitment that we have. But in the short and medium term, it's really about hacking bias among individuals, among institutions, and really creating a measurable shift over time. So bias isn't something that you can break overnight, but what we do is we utilize some of the leading research, particularly around neuroplasticity, this idea that we have the ability to rewire our brain. So what does that mean? It's to become consciously aware of what our biases are, where they come from, what are the origins, the sources of those biases, and then replace them through practice over time. And that way we can actually shift the way we think, shift the way we interact with people, and also just enhance our own personal lifestyle so we're not constantly living in fear of others. You know what Vineet shared about his experiences as a childhood, a lot of that bullying really comes from fear. It comes from not knowing, from this idea of separation, of difference. But I mean, as the Human Genome Project has shown, all of us are 99.9% identical. Like, this organism works the same way. The fear response works the same way. In all of our bodies, it's just manifests in different ways based on how this body is conditioned through the external stimuli. But we can retrain the mind, we can retrain the body. So really doing that both at the individual level, then institutional level, and at a societal level.
And Maria, do you think that it is for the people you work with a more effective way to think about challenges and in a more practical way, solutions, to put it in concrete terms? We're going to try and achieve this in 10 days or 10 weeks, or do you think that you might think in those terms, but to express that is not necessary or even effective?
I found that it's helpful to be very structured about it, and make a commitment, make a goal that's specific, a goal that's measurable, where you can say, now it has been achieved, you can check it off, and something that's time bound, where we use the SMART goals model for our program in order to help the women who go through our program as language access fellows to go from not being an interpreter to then all the steps it takes to become an interpreter, and then all the steps it takes to to get your feet wet in the profession, get started, and then all the steps it takes to advance and stay in the profession.
How long a process is that for the average fellow, language access fellow?
So it takes about 3 to 4 months to earn a medical interpreter certificate, and then from then on we work with our language access fellows for years. We've been around for 5 years, and we're still working with our interpreters that were from our first class, and we see them go from getting the first interpreter jobs to starting their own freelance interpreting businesses.
That's great.
And advancing in other ways.
That's great. And what are your thoughts on this, Vineet? Do you like this kind of structure? I mean, some people might balk at the structure. They might say, I prefer to be more free form about it. Don't put this, you're like me. You seem like you like structure. But I feel the structure coming. I feel it. We're side by side. But tell me if I'm wrong. Or do you like it? Do you like this kind of 3x10 approach? Somebody on Monday night, Catherine Finney said she had 10 minutes. I do 10 minutes. I go in my closet and I'm thinking about 10 minutes. I'm not waiting for 10 days.
Yeah.
And then she had a 10-year plan. I mean, she was 10 by 10 by 10 by 10 by 10. So she really liked her structure. But some other people might say, this is just too much. I prefer to be more fluid about it.
Definitely. I think the structure works well in most circumstances. For us, I think it's what's our sort of 10-year vision as an organization? Where do we want to be in 10 years? What do we want to achieve? And what we do essentially involves leveraging technology as a way to improve quality of care in healthcare organizations serving the populations that we serve, particularly mobile technology and connecting doctors, healthcare providers, nurses, care managers with patients, and creating that bidirectional communication that can enable patients to be more informed and also create greater efficiencies and improvements in workflow for providers. In 10 years, we want to be able to reach 100 million people across the world. Like, that's our vision. We're at about 1% of that right now, but I think that's the broader goal, and obviously that's something that we have to think about in terms of years and not months.
Right.
But at the same time, I think there's elements to what we want to be able to do in 10 years that go beyond just purely numbers of people that we have reached. We're very committed to becoming an organization that's self-sustaining, and that's a critical component of our strategy. We want to be able to leverage the value that we're creating in the healthcare system to be able to sustain our overall operations and growth and innovation in the core products and services that we're developing. And then finally, I think at a 10-year mark, we want to be able to leverage the incredible amount of data that we're collecting. We're collecting millions and millions of data points every single month with the interactions that we're having with our patients, to be able to create a database of insights around our population that can help drive policy. Because we believe that no one has really taken the time or taken the initiative to understand our patients, potentially as well as we have and could in the future. And the information that we're collecting from our population can actually help drive policymaking at a regional, city, regional, and or national or international level, because of the fact that we're collecting all this data from people around their health or around their daily life that can help influence decisions. So that's what we think about long term.
Yeah.
But in order to break that down, we have very specific, year over year goals that we commit to ourselves and commit to our board and commit to our funders and donors regarding how many people we're going to serve, how much closer are we going to get to that sustainability model, and then how will we increase our ability to get better at collecting data.
So you're very much working along this kind of a model.
Maybe not 10 weeks or months, but yeah.
Measured.
That's
very
right.
measured. And 10 years seems like a long time, but it's going to go like that.
Yeah.
But don't worry. Okay. So anybody finding this to be a challenging task? I'm not going to ask you to talk about it. Just raise your hand. Put your card up if you're finding it to be challenging. All right. I like the honesty. Thank you. Anybody have a few challenges or one challenge? Anybody have one commitment written down? Nobody? Nobody has one commitment written down? Oh, we have some work to do, people. Nobody? Wait. You have a commitment? Do you want to share it or not yet?
I'm happy to.
All right. Don't do it yet. I got to get a mic. Go ahead, Ricardo.
Hi, my name is Scott, and I
Thank you,
am
Scott.
actually with Echoing Green. I'm not a plant, though. I'm not a plant. But those who I work with and I'm friends with will know this is something that I am conscious of right now, which is that as a gay dad with a daughter, I'm very aware of gender issues and gender representation and gender expression, and so becoming more aware of what the obstacles to sort of fair and equal and sort of inclusive care for transgender people means. So something that this is actually a great way of structuring for me things that I want to do, and saying that in 10 days I will have a conversation with my pediatrician and see how she feels and make sure that she is on a similar page with I am, that she is my daughter, but she is yet to be able to sort of self-identify as anything. And so this is somebody we got to care for her and care for her body. If there's going to become a point where she needs to express herself and we need to care for her mind and care for her as an individual, regardless of how that is expressed. So a lot of my commitments are really about sort of conversations in the healthcare system in ways that sort of address her and address gender expression.
That's lovely. Do you think you can get an appointment in 10 days? You might need to make that a 10-week.
Maybe 10.
But that's okay, because that could be a two commitment thing. That is lovely. And a commitment can be both personal and political, right? Right? Do we agree? Do you agree, Scott? Scott, right?
Scott, yes, I agree. Well, because I'm thinking that even if it is highly likely that my daughter identifies as cisgender, heterosexual, but I still think that both for her and for the doctors that I speak with, knowing both of them, I want both parties to know that I care about this issue and that they should be thinking about these as well.
Because just in having the conversation with the doctor, who will then see other children, you're making a point.
Precisely.
You're making a point. Thank you, Scott, very much. Okay. Do folks have questions? Questions beyond making commitments? Questions? I'm going to make you ask a question, because I used to be a law professor, and you know what they do in law school? They just call on you. Right, Anu? Folks must have questions. You didn't come here just to listen to me talk, because I will just keep talking. Anybody have any thoughts about what you've heard so far? Oh, yes, all the way in the back. You're going to make me run all the way to the back. All right. Will you kindly share your name as well? You don't have to give an affiliation, but share your name so we feel like we're having a conversation.
Sure, I can. My name is Luis Torres. I'm actually a student at the Icahn School of Medicine at Mount Sinai here in New York. And I can actually identify with the story from Maria, because I was that kid with a single mother from El Salvador who, translated all the time for my mom. But the biggest thing that I want to talk about is, especially for Maria and Vineet, you guys seems like you're really focusing on things like population health and the social determinants of health, which a lot of times doesn't get a lot of press because we typically think of our healthcare system as a place where you go in when you're sick, whether you have cancer, some sort of infectious disease, or you have an accident. But in reality, the goal should be to keep people out of the hospital to begin with, right? So dealing with these chronic diseases, creating approaches that keep people from getting diabetes, keep people from getting heart disease, which are preventable diseases and even reversible diseases to an extent. And I think the approaches that you guys are taking, which for Maria is approaching poverty, right? So for a lot of these populations are very poor, and poverty is an extreme determinant in your medical status and your medical health. And I think influencing that ability is something that, even though it's economic, is still very important to deal with when you're talking about our healthcare system moving forward, regardless of who the president is in the next 4 years. So.
Maria, do you want to respond to some of what you just heard?
Yes. So kindred spirit, hello. Yeah, I feel like I have so many thoughts on this. One is exactly, you're right. The women that we work with, we help them to become medical interpreters, get amazing careers, make a lot more money than they're used to making. And that changes the health determinants for them, for their children, for their families, for their neighborhoods. And we're hoping for a ripple effect across the country that way. And then on top of that, as medical interpreters, they become our partners in providing language access to patients for whom, that having an interpreter there or not can be the difference between life and death, or cancer caught too late and in time. So there's that. I was thinking one other thing, but I forgot it now.
Your question was also directed at one of our other panelists. Was it Vineet?
Yes. So with Vineet, with Vineet, the thing is, so you were talking about these people that you met in Galveston that would kind of, over time, their conditions would get worse and worse. They would come back to the hospital, and it's not for lack of seeing the physician, right? It's lack of resources and poverty, most likely, right? People of color. And you were talking about with your own journey where you were transforming, but this lack of resources, right? So usually these people don't have lack of education. Generally speaking, they know what healthy is to an extent, but they just don't have access to it. Either they can't afford gyms, they can't afford nutrition, they can't afford healthy food. And I think going back to the idea of providing resources in an affordable and easy way where people are not easily as accessed is another important way to address population health in general.
So sorry, what's the question there? Sorry.
There wasn't really a question. It was just
Giving you a shout out. But I do want to ask you, Vineet, about that, because some of it is about education on healthcare, right? When I was reading up on you, because often we put other things ahead of educating ourselves about our health and what's good for us. We think, well, I got to feed myself, I got to pay my rent, I got to get to work, or I got to find a job. And then we get sick and we think, wow, I should have thought about what I was doing. And now here I am in the hospital with no insurance, et cetera. Can you say a little bit about what you've seen in that regard?
Yeah, I mean, I think it's not an either or, it's a both and. And I think fundamentally it's a prerequisite, education is a prerequisite to any sort of change that you can anticipate. But I think it's not just education, but it's education combined with a sense of accountability, right? It's a way for people to feel connected to someone that is keeping them accountable for a specific set of actions or outcomes, whether it's themselves or whether it's their provider or whether it's I want to be there for my granddaughter's birthday, right? Next year. It's a number of different things, but it's creating that sense of accountability to a particular outcome. And I think to your point about resources, I think that's where I think our healthcare system maybe hasn't focused as much on creating avenues for patients to access those types of resources, because those resources are out there. I mean, I think there are ways in which people can, take advantage of some available resources for them to help them to make better decisions on a regular basis. But I think that creating that connection, for example, for things like Meals on Wheels programs that are available to people that they can take advantage of, but many of the patients that we work with have no idea that those programs even exist, or medication access programs that are available to people that can't afford medications or can't afford copays. So I think it's part of it, I think, in terms of creating that engagement between the healthcare provider and the patient, has to do with creating a sense of accountability combined with an contextual understanding of that particular individual and what challenges that they're facing, and how can you link that individual and the unique set of needs that they have with the available resources that are out there, and create that sense of efficiency. I think we've failed to do that. I think primarily because it's extremely onerous and time consuming and requires a lot of effort to do it. So if you can create more efficiencies in that process through the use of technology, for example, like we're trying to do, that can ease the burden on these already overburdened healthcare organizations.
And I remembered now what I was going to say. Yeah, could you tell? So when you mentioned preventive care, I was thinking, immigrants are often, scolded in the media about overusing the ER, about not getting, going to a regular doctor, but, and it's blamed on culture, saying you're from some country where, you just show up and you sit and you wait, and the ER kind of works like that. So you come here and use the ER. You won't book an appointment, and that ends up costing a lot of money. And, in some cases it may be cultural, a matter of habit, but there are also other reasons why that happens. For example, I know of several cases where a patient has called their primary care physician, made an appointment, everything was all set, and then said, hey, but I'll need an interpreter, and was told, oh, if you need an interpreter, you can't have it next week, come back in 3 months, we can book it then, or go to the ER where they have interpreters 24/7. So a lot of people who don't speak English well enough to do it without an interpreter are pushed to the ER. And in New York, that's, almost 40% of the people who live here born abroad. That's a lot of people who might be forced to go to the ER. And then, oftentimes immigrants don't feel welcome in the healthcare system. And if you're not welcome there, if you're not going to be helped, then why bother to go unless you're, on the verge of death? And, that can be pretty dramatic. Like, imagine if you're an immigrant who has been raped and is going to seek medical care for that. Imagine just the trauma and humiliation of having to mime while you're there. That happens, and in that case, is it maybe better not to go?
We have a comment here. May you tell us your name?
I got it. Should I hold it?
Can you stand and tell us your name?
I'm taller this way.
Okay. Tell us your name.
I'm Martha, and I just appreciate so much all three of you coming to address such important issues from such different angles and chipping away. I'm a healthcare provider myself, and I'm a midwife. And internationally, midwives are the chosen providers for women all over the world. Better outcomes, less money, except in the United States and South Africa. Those are the two countries where midwives are not the primary care providers for women. So saying that the providers exist isn't entirely true in this country, because we do need about 20,000 more midwives to provide the care for women in this country that they deserve. But the other piece of it is an educational question about when a person goes into some helping profession, whether midwifery, as an MD, as a DO, they don't get trained at the very beginning to understand that they bring exactly what you are all talking about themselves to it, and therefore that's that's the limit. That's, for many people, that's the limit of their understanding of who they're going to care for. And because I've worked in New York City hospitals and in private settings, I've witnessed incredibly abusive behavior towards young, particularly young, non-white patients by all types of people, but I hate to say it, mostly the white, male, patriarchal society that has written the book on medical care still to this day in this country. So for me, from what I've experienced, I think we need to go back to the educational settings, start at the beginning. If you want to go into the helping professions, you need a lot more than just understanding how the human body works. And you all three are addressing in your own ways that issue. And also, I just want to say that the major midwifery organizations in the United States, which are MANA, Midwives Alliance of North America, and the American College of Nurse Midwives, are currently both seriously addressing the issue of equity in healthcare through the midwifery model of care. Specifically, one issue that's come up very strongly in the last 2 years is care for transgender people. Because, and this came up with the gentleman, Scott, about his daughter, if a person identifies, however they identify, if they want to receive care from a midwife or a female provider, regardless of what their driver's license says or their birth certificate, they should be entitled to do that. And unfortunately, we don't have that set up in the United States yet. And because of what's happening politically right now, that might become even more difficult. So I know we're trying to stay out of the political realm, but I'm of an age where I cannot believe that we're going to relitigate everything, including Roe v. Wade and women's health care in general. We're relitigating that right now on the political front, and many of you aren't old enough to know this, or to remember this, but we've fought these battles for decades, and now we're fighting them again, and it's very disheartening. So I just want to say I'm so happy to see young faces bringing this energy to this fight in your own ways, and it is a huge battle, and the fact that we have a medical system that is completely based on profit means that we all are at the mercy of the organizations that if they don't benefit financially from what they offer, it's not sustainable for them. So that's a whole other issue.
Thank you, Martha. I think we can gather your commitments. We are not trying. You live your commitments. We are not trying to stay away from the political. And I am old enough to remember Roe versus Wade. I'm old enough to remember Loving versus Virginia.
That's right.
I was born. Oh boy, questions. Thank you, Martha, for your work and for your commitment. Yes, will you please tell us your name? Eunice. And don't be afraid to go to the political. That's what we're here for. Not that you would.
I have a question.
Oh, yes, Apollo Uptown Hall. You go, WNYC, Martin Luther King, Sunday. Please join us, 3 o'clock. Okay, enough forward promotion.
Just to give a backstory, a dear friend of mine suffers from sickle cell disease. And she has told me that there have been more than one occasion where she's avoided pharmacies, she's avoided seeing doctors or seeking treatment to avoid the questions and the stares and just the judgments that she's drug seeking. And in my mind, I try to be more empathetic to her situation. Some people would just, shrug her off and say, well, that's unfortunate, or, I don't really identify with that problem, so it's not a problem that I should really take into consideration. But what are some everyday steps we can take or actions we can take to be more sympathetic, more empathetic, to understand where someone else who's facing a certain challenge we might not deal with on a day-to-day basis? How can we be more empathetic to their situations?
Can I just ask a follow-up?
Sure.
Has she, when she has sought help, has she been confronted with that kind of a reaction, or has she told you that she has been confronted with questions about drug seeking? And And so this is a reaction to the reaction she has experienced?
Well, fortunately, she's encountered providers who've been understanding, and these are usually providers that work with populations that have sickle cell disease, so mostly African American individuals or patients. But when she goes to fill in prescriptions, that's where the questions come.
So it's the pharmacies.
Right.
Any thoughts on this, or is this within your area of expertise, or a referral perhaps? I bet I knew you have some thoughts.
Well, first of all, thank you so much for sharing. I mean, this is quite common, and you've shared one example, but it's very common for patients of color, particularly African American patients, to experience such social distancing and outright hostility sometimes by providers, which is why we have some of the disparities that we have across different disease and areas. I think one of the things that, I mean, our job, I mean, like Martha shared, what we're trying to do is actually train healthcare professionals. Our job is to train them and really embed this type of training within medical schools, within pharmacy schools, within nursing schools, so they get that training up front to understand what bias is, but then also how to hack it, how to break it. So in terms of your question is like, how do we become more empathetic? It's actually first understanding the barriers to empathy. What are the assumptions that we're making about this person who has a disease which is something that he or she didn't ask for, but it's part of the genetic inheritance? One of the things that I'll say around sickle cell is that it's oftentimes conflated as a black disease, but it's not. It's basically a disease that's part of the equatorial belt. So there are people in Greece, in Turkey, in India, and in Italy that have sickle cell disease, and oftentimes the African Americans who have sickle cell are basically descendants of individuals that come from North Africa, right, or West Africa, where this was evolutionarily developed to combat malaria and other things. But you can be African American and appear white and have sickle cell, right? So you can actually be not just passing as white, identify as white, but you may have one ancestor, and that's passed down. So we don't know how it actually happens. So that's one of the misconceptions that needs to be clarified. First off, it's not a black disease. It's a disease for people from a certain geography. Now, in terms of building empathy, that's really about listening and understanding the pain of another person. And now what's happening from the healthcare provider side is, what are those barriers to be empathetic? Now, that's not something you could do, but as someone who's training to be a professional, it's basically about, just literally writing them down. What are my assumptions about people with this disease? Do I think they're abusing it? Where do those assumptions come from? What sources are they coming from? And a lot of that reveals to us, again, the unconscious beliefs we have. Whether it's media, whether it's, because that one person I know, they were abusing drugs, so I'm sure all people abuse drugs. But is that, reasonable for a disease that, basically has hundreds of thousands of people? So really kind of beginning to question that. And the third thing, this is one of the strategies to really break bias, is mindfulness. So literally breathing techniques. So the second something like we talk about cancer or HIV or sickle cell, our body just stops, Suddenly we're like checking ourselves, and it's like, okay, breathe. Like literally take a moment to breathe in, breathe out, and begin to see where that contraction is, and then be open.
Which gets back to what Martha was saying about the training
Precisely.
in the medical profession, right? But it sounds as though your friend has healthcare providers who are treating her with a measure of respect. And the problem is when she goes to fill the prescription. And I would think that there are probably legal remedies there, discrimination, et cetera, and thinking like a lawyer. Right. And maybe she could go back to the healthcare providers and try and seek a remedy there if she's being denied the prescriptions that are given to her when she gets to the pharmacy, which it sounds like is what's happening, right?
Right. And she's also had encounters where before she had a full-on hematologist that she was seeing consistently, when she would see one-off providers,
Right.
the questions would come as well.
No, it's really it's complex, and particularly because we live in a country that's a third, black or Latino, but less than 10% of providers are Black or Latinos. There's already a huge disparity there. I am not a big fan of, as an attorney, I'm not a big fan of legal remedies because one has to prove intent.
Understood.
And that's a huge bar for someone who's already sick, who's just trying to seek remedies. So I think part of it is like, what tools and strategies can she develop to confront discrimination that she's going to continue to confront without letting that get to her, right? So she can continue to live a fulfilling life for herself regardless of what others are perceiving her to be, right? That's kind of the empowerment work that we'd like to do. Because part of it is that racism has been around for 300 years, 500 years since, the idea of race was invented. And it's not going to go overnight. But how can we really deal with that now? Dr. King said, a week before he was assassinated, that, I was really committed to integration, but I didn't know I was integrating us into a burning house. Right? So there's a reevaluation of values, our commitments that we're going through right now, politically at the meta levels too. So I think, but during this period of transition, I think all of us, particularly your friend, really needs tools to be able to deal with that without questioning herself and her own beingness, because that's just her humanity.
And I've got some thoughts on that as well. I think often when people experience a situation like that, where you go somewhere and you're suspected of being a drug user, she wouldn't be suspected of that if she was white. She just wouldn't, and we know that. And I think when somebody tells us a story like that, there can be an impulse to empathize with the person who did the wrong thing and say, well, they're just trying to do the best they can. Or, they're dealing with all these people who are, addicted to painkillers or whatever. We kind of like have a tendency to explain to them, no, it's not so bad, it's not so bad. And the intent, of course, is good. But sometimes it has the effect of making the person feel kind of crazy and like they're overreacting or they shouldn't have brought it up anyway. And I think we as a community, when we hear things like that, we need to tell your friend, they're crazy. That's not okay. They're doing their best, but their best is not good enough. And that's not okay, and be outraged together with the people who are on the receiving end of the wrong, rather than try to sort of, pacify them and say, it's not as bad. The intent was okay.
And to your point, Anu, the whole thing about litigation is then you get all caught up in this litigation and you get anxious and you get worked up, and the plaintiff, the friend, has to propel that forward, and it is not a healthy experience. Sometimes it's the only option, but it's not a healthy experience. Absolutely. I have time for one more question. Okay, two more. And if anybody wants to lay out their commitments, I'll take them. And then I want to hear from the panel on what commitments you need from us to do your work, to move it forward. Okay. I'm going to hand that to you.
Yes.
Okay. I'll get it.
Hi, I'm Clara, and thank you again for being here. This has been awesome. I'm a statistician at one of the hospitals here, working with clinicians in and out, day in and day out, on different projects and questions that they have about healthcare. And one thing that I found with clinicians and really with all of us is that we know we live in a racist society. We know we live in a judgmental society, but I'm not racist, but I'm not judgmental. And we all think this, and so I guess my question for you, Anu, is how do you convince a clinician, A, that you need it, and B, that it's a priority? And my recommendation as a statistician would be to use Vineet's data. Because I would really love to see what the care messages are back and forth. And this has been done in, most interactions are oral, they're not recorded. And most things, like, what they encounter are not recorded anywhere, but sometimes they are. And that is in phone calls and a lot of patient emails back and forth with nurses. And people have started to look at those and started to see that there is bias in those. And it's a lot easier to go to a clinician or go to a medical school president and say, look, we need to be training on this because I know that you think your training is enough, but it's not. I know you think that other doctors are racist, but not yours, but that's just not true. And so I just see this synergy between the groups here and just in general about recording things and getting your data as soon as possible to people who are out there. And there are a lot of nonprofit statisticians out there who would love to take a look at what we can do, and then have a stronger message for clinicians on your side as well.
I'm going to walk this mic around to you because I don't want to drop it. But I also have to throw this question, and can't throw it to all three of you because I'm looking at the clock and we have a lot we have to do in 10 minutes. So I'm going to ask you, Vineet, this question because it's really important to get this energy out, and that's the energy of optimism. Because I feel it from you three, and I want to know how you maintain that optimism given what we're all talking about, right? So... and you guys can pile on to what he says, okay? I can't shut down the optimism. But let me just ask you, Vineet, how do you, given what you presented as the problem and the work you're doing and your 10-year plan, which is pretty daunting, how do you stay optimistic?
Yeah, great question. I think it's easy to be optimistic when there are a lot of signs that point towards progress, and both in terms of the work that you do as an entrepreneur, as well as the work that others are trying to do to strive towards the same vision. And I'm personally encouraged by, everyone here that is committed to proving healthcare equity for people all across this country and hopefully across the world, if we're able to do that. In our own unique ways, right? And the person who said that, they would like to march for reproductive rights in 10 days is contributing towards, even though the work that CareMessage does is not directly related to that, it's all trying to help provide that. The reason we're successful as an organization is because there's so many people that have come before us that have made it possible for us to do the work that we're doing. So if our goal is to simply build upon that in our own unique way, then you can't help but be optimistic about that, because you have seen examples where people have made that kind of progress in the past in creating, Lyndon Johnson Great Society legislation that made Medicaid possible in the 60s, that allowed people that were poor to get access to care that, organizations like ours could build upon. So I think that's why I'm optimistic. A second related reason why I'm optimistic is because I'm really bullish on technology, and particularly bullish on mobile. I'm not trying to diminish the value of non-technology solutions. In fact, we need those as well. But I think technology is an incredibly great enabler, and it's significantly underutilized in the industries that need it the most. Particularly healthcare. And so I think that there's incredible power in making systems more efficient, in making people and leveraging the precious resource we have in people, and making that more leveraged, I guess. I can't think of a better word than that, using technology. So I feel excited about that.
I think part of it is just congenital as well. If you look at us, one thing I was struck by with both of your personal stories is that, same as with me in a way, just as you're fighting to make the world better, you're also surviving it in the very same way, and it's hard. And I think, the three of us and other people who start organizations, who work for organizations, who kind of, fight these uphill battles, I think it's just deep-seated optimism within us, and we just have to keep plowing forward.
Well, I just look at the big picture. Think about humanity 10,000 years ago, 1,000 years ago. Someone who looked like me couldn't become a citizen of this country less than 50 years ago because of my ethnic background. So part of it is really looking at, how much change has taken place. 40, 50 years ago, half of humanity, women, couldn't participate in our economy. It's such a short period of time. So I think that while we have these ideals of wanting a better world, and we ought to have that, it's really up to us to create that world. So I think for me, looking at reality and the challenges is inherently optimistic because these aren't challenges or problems. These are opportunities for us to really transform the way we live and the way we interact and to build connection. Solutionaries.
Okay, tell us your name and then ask us a terrific final question.
That's a lot of pressure. My name is Arafel, and my question has to do with implicit bias, but then really branches out more to solutions. So I work in communications, and there's a category of folks who hear the term implicit bias, and it's mobilizing for them. There's a call to action there. It's almost startling that this has been inside them their whole life and they've never known. And then there's a whole nother camp of folks that can almost use it as an excuse. As it's not just me, it's everyone. Everyone has this. I can just continue this way. So my question would be, what is your call to action to those folks? And how can we mobilize maybe the people that wouldn't as naturally be engaged with these messages to actually get involved in the solutions?
Yeah. Thank you for that question. I mean, I think it's a really appropriate question, particularly because implicit bias is in the air. I think the first thing, and I think this is one of my challenges for you all the next 10 days, is to have everyone take the implicit association test or the IAT. Just Google that. It's going to take you under 2 minutes, but to really understand what our preferences are, you know, at an emotional level. What are the associations that we have when we see white people versus black people, when we see women versus men, you know. So that's one thing, is to become aware of it. But I think that's where the indifference really comes in. And this is a cynicism that's kind of pervasive in our culture. It's like, oh, all of us have it. It's just part of human anatomy. I'm like, not really. You know, yeah, human beings need to differentiate between fire and water for safety reasons, but not between dark-skinned and light-skinned people and treat them differently. That's called discrimination, and it's illegal. So part of that is institutions really need to make an effort to combat and hack bias, to break bias among individuals. So part of it is that I think this is where there's a difference between individual agency and institutional agency. And I think our strategy at BMOR is to really target institutions. So everybody that works at institutions, whether it's hospital systems or medical schools, everybody gets trained to really break bias. And then to be able to shift cultures, which is essential to shift policies and practices that continue to create inequities based on race or gender in other ways. I think the other thing that I'd like to say around how do we combat indifference, this really goes back to your comment, actually. This is around languaging. So we have made a conscious decision not to use the word racism, that we don't say that we live in a racist society, because the evolution of that particular term really came out in the 80s, which had a specific historical background. Now, a lot of focus group research has shown that when someone says that this is a racist society or someone is racist, there are images of, you know, burning crosses of the Holocaust that arise. Mm-hmm. And the reason why people deny it so quickly is like, I am not a Nazi. You know, I'm a doctor. What are you talking about? I have, you know, committed my life to public service. So it's really about transferring that language into bias. We have racial bias. We have gender bias. And it's not something that's inherent in us. It's something that's learned, right? Human beings have learned to categorize, and we have learned to, you know, impose specific qualities onto people, but we can unlearn it. And that's the way to really bring them in. So this is where a lot of the research of Brené Brown comes in. I don't know if you know about Brené Brown. She gave this incredible TED Talk on the power of vulnerability. And she's a scholar of the human emotion shame. And basically, shame prevents shift in human behavior. So we can't shame people into being part of this conversation. We have to invite them. So that's it.
I think that's a wonderful... I wish I could end there, but I can't. Because I do want you each to share, if you can briefly, although that would be such a good place to end, the commitment you would like us to think about making to help you in your way forward. Are each of you ready to do that?
I've got a whole menu of commitments.
Well, you can tweet out the menu, but Maria, why don't you start us off? Can you give us one good one?
I saw a lot of hands for people who are struggling with making their commitments. I have 1 in 10, 1 in 10, 1 in 10. Is that okay?
Okay, if you can do them
pretty
quickly.
quick. So in the next 10 days, just start a conversation with any one person and ask, hey, did you know that access to a professional medical interpreter is a legally protected civil right in the U.S.? And I'm wondering, show of hands, who didn't know that before I said that today? Ooh. See? So do that. I think that's an important place to start. And what's really scary is a lot of health providers don't know this, and a lot of people who need an interpreter don't know this. So I think anyone can do that in the next 10 days. In the next 10 weeks, I'm sure most of you, if not all of you, know somebody bilingual who you're going to see in the next 10 weeks. Ask that person, have you considered becoming a medical interpreter? Because maybe they've never even heard of that, and we need medical interpreters. Patients need them badly. The populations are changing. The medical interpreter workforce is actually kind of old. And over the next decade, we're going to need replacement young interpreters. So ask them, and feel free to reach out to me. We're not based in New York, but I can probably hook that person up to something closer if they're interested in entering the profession. And I think for the next 10 months, if you want to go bold, go to your medical provider, go to the pharmacy, or, if you happen to be there, and ask them, what do you do about language access services? What are your interpreter services providers? They all should be able to say what they do and how they do it, and it should not be, their family comes in and does translating for us. But if you don't want to do that, then I encourage you to go deep and just look into this issue, because it's not something that gets talked about a lot. And one place to start, if you want to get like a deep understanding, is there's this amazing book called "The Spirit Catches You and You Fall Down."
Beautiful book.
Yeah, it's great, and it's about a Hmong family who goes through the U.S. medical system. And there are language barriers and cultural barriers, and that can be, if you haven't read it, one way to kind of acquaint yourself with the issues.
That was 4. But they were great. Thank you. Are you ready?
Sure.
You've been ready.
I think so. I have a very simple ask of everyone. I want everyone to make one call to your congressman and or your senator, preferably both. 2 calls, maybe. And tell them why you think that taking away health care from 21 million people is a bad idea.
I knew we'd get back to that.
That's it.
That's good. Thank you.
Thank you. That was, all of these, and... So
I see people taking notes.
So there's no time on this. I mean, you can do this in the next 10 days, 10 weeks, or 10 months. But I'd like you to go out for a dinner with someone you fundamentally disagree with. Someone from the opposite end of the political spectrum, gender spectrum, you name it. Perhaps someone, you look at your list of friends, you're like, I have 0 friends who are Spanish speaking. So perhaps a coworker, perhaps someone you meet on the street, have dinner. So that's a commitment, right? It's an hour-long commitment. It's not coffee. You can't run out in 15 minutes. But more importantly, the next 2 things. During the course of your conversation, you share with them and you ask them 2 things. What breaks your heart? And what brings you alive? So, what breaks your heart? What brings you alive? Maybe start the conversation there and have that conversation. And then tweet at me or at Be More America and tell us how it went.
Common humanity.
Common humanity.
Good. Wow. Okay. Maybe that person would be your congressman. And then you could talk to them
or
about being an interpreter.
If you get an interview with him.
Get it all done at once. Okay, I have to recognize someone here. You know it's coming, so put that pad down. Yes. Cheryl Dorsey is here. She is the president of Echoing Green. You have to stand up. Oh, come on now. And I have to say, she's a former Echoing Green Fellow, indeed, and really a visionary in this work and a leader. And if you don't know about her work, you should. So look into it. She's, one of my heroes. And I think going to be a force in the next 4 to 8 years. Someone we're going to be looking to for some leadership. Cheryl, thank you so much for bringing these young people to us. There are 700 of these people out there. And it was a very small organization. This is the 30th year of Echoing Green. Wow, right? So congratulations to Echoing Green and to you, Cheryl. So I want to say I do not have my cards because when I got up to do my little Oprah thing, I left them over there with Eunice. Thank you. Would you like to do this part of the program? Well, I want to thank you all for coming. I want to thank you for your commitment to this work and to this cause, and I'm sure to many other important causes. I don't need the cards because now I know these people. Besides that, you took my slides down because that was going to be my cheat sheet. But I don't need it. I want to say thank you to Maria, to Anu, and to Vineet for your important work and for your time with us tonight, and most of all for inspiring us to make commitments to what you do. And I hope you'll come back maybe in 10 weeks or 10 months, hopefully not 10 years, to tell us how it's going. Thank you so much for your time.
Thank you.
And they'll stick around for a few minutes if you want to talk with them a little bit more about any specific ideas that you're working on. Thanks again.